Hello and welcome to this Asia Pacific Glaucoma Society webinar on how to identify and manage progression in glaucoma. My name is Colin Clement and I'm pleased to moderate this session along with my colleague Professor Makata Ihara. Now before Professor Ihara introduces our speakers and topics, I'd like to remind everybody of the benefits of becoming an Asia Pacific Glaucoma Society member. You get a registration discount for attending the Asia Pacific Glaucoma Congress whilst your membership is active. There's also access to online education materials, including the webinar series and surgical videos. We produce a quarterly newsletter. Members have access to the online communities. There's also free online access to the Journal of Glaucoma, and you get to participate in the electoral process for the various Asia Pacific Glaucoma Society committees. There's the right to participate in the collaborative activities of the Asia Pacific Glaucoma Society with international affiliate societies, and there's exciting and valuable professional networking opportunities. And of course, there's the eligibility for awards and recognition. The APGS has been involved in a number of exciting recent collaborations with international societies to provide online webinar educational material. This includes the American Glaucoma Society, the European Glaucoma Society, and the International Society of Glaucoma Surgery. And today's webinar presentation is a continuation of that commitment to ongoing online education. So with that, I'll hand over to my colleague, Professor Ihara, to do the introductions. Thank you.
Hello everyone, welcome to APGS webinar. So today's session is medical management in glaucoma. So this session was supported by Aragon. Thank you for the kind support for our webinar. So I'll introduce the four speakers of this session. The first one is Dr. Colin Clement from Sydney, Australia. He will talk about glaucoma and QL, how big is the challenge. And next speaker is Professor Mimiwati Zahari from Malaysia. She talked about factors impacting progression. And the next speaker is Professor Chris Leung from Hong Kong. He will talk about assessing progression in glaucoma. And the last speaker is Dr. Ronnie George from India. He will talk about management of progression glaucoma, when and what. And so Colin will moderate this session. So let's enjoy this session.
It's my pleasure to open this webinar session on the topic of glaucoma and quality of life. How big is the challenge? I've framed this presentation in terms of our current ability to measure quality of life and where we need to be in the future. I'd like to start by posing a question, and that is, what is the goal of glaucoma treatment? Well, of course, our primary goal is to maximize quality of life. But we don't do this directly. We do it indirectly by preserving vision, and we do that indirectly by lowering intraocular pressure. So what our treatment aims are in the clinic are a couple of steps removed from our primary treatment goal, which is to maximize quality of life. Now, paradoxically, when it comes to lowering intraocular pressure, we have a very comprehensive understanding of how this is beneficial in terms of preventing glaucoma progression and preventing further glaucoma-related field loss. And this is based on many clinical trials. Similarly, we have a strong understanding of how our many interventions can preserve vision in patients with glaucoma. But when it comes to maximizing quality of life, it's safe to say that we're still on a path to understanding this, and our understanding is much less than that of the benefits of intraocular pressure lowering and preserving vision. And to put this into context, I will present this scenario to you. We face this situation on a daily basis in the clinic with a patient discussing the potential benefits of treatment. If you're proposing to treat someone medically, and say, for example, we're going to start them on a prostaglandin, and they asked you what would the benefit be in terms of the intraocular pressure reduction, well, we can quite easily say with great confidence that the pressure reduction on average is going to be around about 30%. And similarly, for surgery, if they ask you the same question, you might say, well, I can with confidence get your pressure down to 10 to 12 millimeters of mercury on average with a traditional filtration surgery. Similarly, they might ask you, well, with this medical therapy, what's my risk of preserving the visual field over the next couple of years? And you could say, based on clinical trial data, that we can reduce your risk by 40 to 50%. And similarly with surgery, clinical trial data shows that it's similarly beneficial. But curiously, if you're posed with the question of what would this medical treatment do for my quality of life, or what would this surgery do for my quality of life, that is very difficult to answer. And I wouldn't have a straightforward response to that question as I would for questions surrounding intraocular pressure or visual field changes. And that's true for both medical therapy and surgery. And equally, you're very unlikely for patients to ask you in the clinic, what does this do for my quality of life? They're more likely to ask you about pressure and visual field. So there's this disconnect between what we're trying to achieve with our treatment, but what we're actually able to describe in terms of the efficacy of our interventions. So the question is, why is our understanding of quality of life so poor? Well, I've broken it down into three areas. First of all, there's only been a recent shift in thinking in terms of quality of life. In the past, there's been a very strong focus on intraocular pressure and visual field, and it's only more recently where quality of life has come to the forefront in terms of measuring outcomes. Also, quality of life issues in glaucoma are complex, and I will touch on that briefly. And finally, we don't have very effective tools for measuring glaucoma-related quality of life at present, and there needs to be improvement there. So let's look at the recent shift in thinking in more detail. I've presented a couple of examples here just to highlight the issue. Now, glaucoma filtration surgery was described, modern trabeculectomy around late 1960s, early 1970s, and there's been ongoing investigations into the benefits thereafter. Similarly, medications have been studied for a similar period of time. But it wasn't until the 1990s where reports of quality of life as an outcome of glaucoma intervention first started to appear in the literature. And the collaborative initial glaucoma treatment study is really one of the first clinical trials that used quality of life as an outcome measure. Now, they didn't use it as a primary outcome measure. They were more interested in visual field changes, but quality of life was reported as a secondary outcome measure. And they used a number of different questionnaires which they adapted to fit the study they were performing. So that was reported in 2001, so relatively recently. More recently, if you look at the World Glaucoma Association guidelines on designing and reporting glaucoma surgery from 2009, interestingly, quality of life is not recommended as an endpoint to measure in glaucoma surgery trials. And even more recently, the UK glaucoma treatment study, which was reported in the Lancet in 2015. So this is a study comparing primary prostaglandin therapy to placebo. Again, they had no quality of life measures assessing the outcome of treatment. This is very recent. So that highlights that using quality of life as an outcome measure is still in evolution. And we've got a long way to go in terms of incorporating it into everyday practice in terms of both research and clinic. Now, in terms of quality of life issues in glaucoma, these are complex. So I've got here a table reported from a study recently published in the Indian Journal of Ophthalmology, and they looked at 3 different quality of life instruments. The the National Eye Institute Visual Field Quality 25 questionnaire, the Glaucoma Quality of Life 15 questionnaire, and the Viswanathan 10 questionnaire. And they then compared controls to patients with mild, moderate, and severe glaucoma. And they found that there was no difference between controls and those with mild glaucoma statistically, suggesting that using these questionnaires that patients with mild glaucoma do not have a diminished quality of life. However, if we look at another study, and this was published this year from a group in Finland, they used this metric, which is an assessment of depression, and also compared different glaucoma groups to controls without glaucoma, and they found that there was a significant difference between patients with and without glaucoma. And you see on the graph there, the dotted line is indicates the threshold at which the result is clinically deemed to be significant. So all glaucoma groups had measurements above that line and controls were below that line. So those 2 studies are really coming to different conclusions. One, that patients, some glaucoma patients do not have diminished quality of life, whereas the other study suggesting that they do. And this really points to what type of instrument are you using to assess quality of life in the first place. Another issue is that loss of vision and the rate of loss of vision is linked to quality of life. So studies that use vision-specific quality of life measures suggest that the quality of life is linked more so to the vision in the better eye rather than the worse eye. And the rate at which you get to a certain degree of vision loss is important. We certainly know that treatment is associated with side effects, and this has been linked to reduced quality of life as well, whether it be medication and its effects on the ocular surface or surgery. Quality of life measures have been reported to be reduced. And then, of course, there's the impact of testing and follow-up and time and financial burden to the patient. We all know how very anxious our patients get prior to doing visual field testing. The ongoing demand to attend clinic appointments no doubt reduces quality of life, as does the drain on their time and the cost to them. And then finally, I want to touch on the fact that the instruments we use to measure quality of life are not perfect by any means. First of all, they vary greatly in terms of what they're measuring. So this table shows a summary of at least some some quality of life instruments that have been used to assess quality of life in glaucoma studies. Some are just general health questionnaires, some are vision specific. The National Eye Institute VFQ25 is one that's commonly used, and some are glaucoma specific, such as the Glaucoma Quality of Life 15, the Viswanathan questionnaire we've mentioned previously. And And the point here is that they're looking at different things, and the results that they generate are not directly comparable. So if you made a comparison to, say, intraocular pressure measurement, well, it's true that we have many different types of instruments for measuring intraocular pressure, but the results are comparable because they're looking at a metric which is exactly the same, intraocular pressure in terms of millimeters of mercury. That's not the truth for these quality of life instruments. And I've made a comment here at the bottom that no single instrument or one of these instruments captures all aspects of quality of life measures in glaucoma patients. So to try and achieve that, we need to use multiple measurements. So if I come back to this table from our study from the Indian Journal of Ophthalmology, if we just pick one of the results here, say the Glaucoma Quality of Life 15 score for the moderate glaucoma patients, it's 19.38. Now the thing is that I don't know what that means. It's hard to place that in the context of someone's quality of life. Is that someone with a poor quality of life, an okay quality of life, or somewhere in between? Whereas if someone said to you that this patient has a pressure of 23 millimeters of mercury or 19 millimeters of mercury or 15 millimeters of mercury, you can easily put that into context as to what's normal or what's not normal. So these quality of life measures can be hard to interpret. Another issue is how they're scored and weighted. So this is the glaucoma Quality of Life 15 questionnaire with the 15 different items which are scored from 0 to 5. Now, that scoring system in a way is arbitrary. It could quite easily be from 0 to 3 or 0 to 10. And the other thing is that each item is given equal weight, whereas in terms of someone's quality of life, some items may be less significant than others. So there is a degree of potentially inaccuracy in these instruments. The importance of quality of life measures is highlighted by this recent review that was published this year by Gazard et al. And in the summary of this review, which I recommend you read if you have the time and interest, is that in summary, wide variability in the questionnaires used to determine quality of life in glaucoma and in the responses elicited was identified, and there was no single existing quality of life questionnaire design that is suitable for all purposes in glaucoma research. So in summary, it appears, I would say that the quality of life remains the single most important outcome measure in glaucoma management, yet we lack a standardized method for measuring it, both in research and clinical settings. And the outcomes are not currently discussed in terms of quality of life. We're still very much focused on intraocular pressure and field results. So our challenge, and the challenge is significant, is to develop standardized instruments that assess all aspects of quality of life in glaucoma patients, and to ensure the measurements are easily interpreted in the context of a patient's life experience. So we need to work towards adopting these measures both in the clinic and research settings as primary outcomes of glaucoma management. Thank you.
Good evening to everyone present. My name is Mimiwati and I am from the University of Malaya, Kuala Lumpur. I would like to thank the organizing committee for inviting me to give this talk on factors impacting glaucoma progression. I have no financial disclosure. There is a wide variability in glaucoma disease progression and outcomes between patients. Some progress slowly and some progress rapidly that they become visually disabled in their lifetime. Now, what are the factors that can cause this variability in disease outcome? Major glaucoma studies have identified certain risk factors, and intraocular pressure and age has been found to be the strongest risk factors across all studies. There are also other risk factors unique to each individual study. For example, in the ocular hypertension treatment study, it has been shown that a thin cornea is a risk factor for an ocular hypertensive to convert into glaucoma. They looked at other risk factors as well, significant to their study. and it has been found a large cup-disc ratio and a high pattern standard deviation was found to be risk factors for conversion. They use these risk factors to develop a glaucoma risk calculator, which can estimate your risk or a patient's risk of converting to glaucoma in 5 years. And this is very helpful because there's always the question of to treat or not to treat an ocular hypertensive patient. In the early manifest glaucoma trial, the natural disease progression of early glaucoma patients was seen. So in the non-treatment arm, 68 of the patients progressed, whereas in the non-treatment arm, there was still progression, but at a much later rate. So the treatment arm, the patients progressed at rate of 45%. But what's more important to note is that they found out that the presence of pseudoexfoliation increases the risk of progression multiple times. So this is a very important risk factor to detect in our patients or to note in our patients. Older patients have also found to progress faster. And in this study, they found that for every millimeter reduction in IOP will decrease the progression risk by 10%. Now, IOP being the most important factor affecting glaucoma progression. However, there are many aspects or facets of the IOP to be considered. The IOP, one is IOP fluctuation. IOP fluctuates throughout the day and night, and this is due to the circadian rhythm and the body position. So the peaks usually occur at night. Now, how much fluctuation is damaging? In this study, it showed that a large diurnal fluctuation, more than 5.4 millimeter mercury, is itself an independent risk factor for glaucoma progression. Now, long-term fluctuations in IOP was also seen in the advanced glaucoma intervention study, where it is noted that for each millimeter increase in IOP fluctuation, the visual field progressed by 30%. But this was more damaging in eyes with a low mean IOP. So therefore, fluctuation is more an important factor for progression in eyes for NTG, for instance, so which has also been shown in this study. A more advanced visual field loss at baseline is a predictive factor of progression, and this also has been shown across several landmark studies. Central field loss, the presence of it was noted to also be a predictive factor. And in this study, they found that eyes with a baseline central damage progress faster than those without. So therefore, in our clinic, if we see a patient with central visual field damage, we have to monitor them more closely because, as we know, these patients tend to progress faster. The presence of this hemorrhage has been reported to suggest disease progression. And in this study, these hemorrhages was significantly associated with a more severe central damage, both in the central fields and both in the C24-2 fields. So they concluded that this hemorrhage identification, if found in a patient, should prompt the doctor to actually investigate this central field loss. These hemorrhages were also found to be associated with structural progression. In this study, patients with these hemorrhages were found to have a more rapid rate of thinning of the ganglion cell inner plexiform layer compared to their fellow eyes without these hemorrhages, and also compared to the control eyes, the glaucoma control eyes without these hemorrhages. So they concluded that these hemorrhages could be associated with progression of glaucoma in terms of glaucoma cell, the ganglion cell inner plexiform layer thinning. A low ocular perfusion pressure is related to glaucoma severity and progression, and this has been shown to be true more in patients with low tension glaucoma. In low tension glaucoma, since the IOP is already low, it is usually the blood pressure, a low blood pressure, which causes a further lowering of OPP. And this study has shown in their patients that those who the rapid progressors in their cohort have actually a higher rates of cardiovascular disease and hypertension. And the presence of cardiovascular disease and hypertension will increase more than twice their likelihood to develop progressive glaucoma. Now, corneal hysteresis should also be considered as a factor for progression. This study looked at the corneal hysteresis in glaucoma suspects and found out that at the end of 4 years, those with a measure of less than 10.2 millimeter mercury showed progression. Corneal hysteresis is the ability of the cornea to resist deformation. It is believed that it is a reflection of the frailty of the lamina cribrosa behind. So therefore, a low measure is actually more damaging to the eye. Now, reduced intraocular pressure has also been shown to be a predictive factor affecting progression, because a low ICP from this diagram can cause a more deformed lamina cribrosa, mimicking the mechanical factor in the mechanical damage in high IOP. So increased translamina cribrosa pressure difference can occur with either an increased IOP or with a decreased intracranial pressure. So a review article was just published this year and found that most evidence supports the role of reduced intracranial pressure in the pathogenesis of glaucoma. Another paper also found lamina cribrosa focal defects in the patients who progressed. Now, I'd like to share with you a study that we performed on our normal tension glaucoma patients, where we recruited 72 normal tension glaucoma patients and 55 fatigue controls, and did 24-hour facing of IOP and BP monitoring in the ward. There were no significant difference in the baseline demographics of the two groups. IOP and blood pressure measurements were taken 2 hourly in the habitual positions. And what we found was that, interestingly, IOP was not an important factor in NTG. There was no significant difference in between the two groups. However, the blood pressures taken at night, the systolic and diastolic blood pressures, did show that there were significant difference, and they were all significantly lower in the NTG group. Therefore, we concluded that normal tension glaucoma is a nocturnal disease related to reduced ocular perfusion pressure in this period, and this may reflect defective autoregulatory mechanisms in NTG patients. We also used this cohort to prospectively look for the incidence of progression in the visual field. And we found out that in these patients, well, it was the original cohort, but only 7 of them dropped out. At 5-year follow-up, 35% of the enrolled patients demonstrated visual field progression. And when we found out also that the diastolic parameters of the blood pressure and the ocular perfusion pressures were the ones significantly lower in the NTG patients who progressed. So nocturnal events are the main key players that influence the disease process in our cohort. The survival analysis also showed for every 1 millimeter decrease in diastolic ocular perfusion pressures increases the hazard of progression by 1.4 times, and patients with a DOPP of less than 35 millimeter mercury have more than 2-fold higher probability of progressing compared to patients with a deep OPP or in the higher quartile. So we concluded that a low nocturnal DOPP is an independent predictor of glaucomatous visual field in NTG patients. We also looked at the visual fields and divided them into two groups on the basis of central or peripheral defects, and found out that eyes with baseline defects involving the central fields also progressed faster and had a 3.5 times higher hazard of progressing than those with peripheral defects. So in conclusion, NTG patients with baseline central visual field involvement are at an increased risk of progression compared to those with peripheral defects. So in summary, we have seen the factors affecting progression. Sorry, I have no time to actually go through each of them again. But in conclusion, although IOP remains the most important and only modifiable risk factor for glaucoma progression, it is important for us to identify the other factors as well to prevent the loss in high-risk patients. Thank you for your attention.
Thank you for having me in this webinar. In this presentation, I would like to focus on three specific questions that we often ask and discussed when we talk about evaluation of structural and functional changes in glaucoma progression. Number one, do we need to image the macula in the assessment of glaucoma progression? Number two, when do we need tenders to monitor visual field changes? Three, do we need to treat patients with progressive retinal nerve fiber or GCIPL thinning without visual field progression? We need to include the macula and the palpebral region when we evaluate glaucoma and its progression. The very reason is that retinal nerve fiber defects in glaucoma, they are often wedge-shaped, meaning that these defects expand from the optic nerve head region to the macula. It expands in area. So it's actually easier to detect abnormality, to detect retinal nerve fiber defects of the macula compared with over the palpebral region when we have the tool to evaluate retinal nerve fiber layer precisely, accurately over the macula. Here is a technique we developed. We call this ROTA, or retinal nerve fiber optical texture analysis. They allow us to visualize the axonal fiber bundles on the retina. In this case, we're able to see a clear infratemporal retinal nerve fiber defects, and the area expand, the defects area expand from the optic nerve head towards the temporal macula. And with conventional OCT analysis, we also are able to detect greater damage of the macula using the GCIPL. We focus on the GCIPL of the macula because the retinal nerve fiber layer is relatively thin over the macula. GCIPL represents the somer and dendrites retinal ganglion cells. This layer is thicker than the RNFL over the macula. That's why we image the macula, we image the GCIPL over the macula. By contrast, the RNFL, which represents the axonal retinal ganglion cells, they are relatively, this layer is relatively thick around the optic nerve head, and that's why we focus more on RNFL over the palpebral region. In this case, again, macular examination is important because we see greater damage over this area. In this example, we illustrate the fact that how we can use change analysis or GPA, guided progression analysis, to follow our GCIPL over the macula over time and the RNFL over the palpebral region over time. Additional thinning is indicated by red in the change map. In this example, we show progressive GCIPL thinning is detected before we see progressive RNFL thinning. Again, the notion here is that detecting change of the macula is easier than detecting change over the palpebral region because of the wedge-shaped pattern of retinal nerve fiber defects. So does it mean that we can just focus on the macula without looking at the palpebral region? The answer is no, because there are also occasions where we detect change of the RNFL over the palpebral region before we see change of the GCIPL of the macula. So why would that be? We just talk about detecting change of the macula is easier than detecting change over the palpebral region because of the wedge-shaped configuration of the retinal nerve fiber defects. The very reason here is that we need to understand the limitation of our scans. The size, the series OCT, it images the macula, the GCIPL, over a 6x6 macula scan region. But for the analysis of GCIPL, is limited over an elliptical annulus. So when a defect is developing away from the scan region, you are not able to detect change, you're not able to detect these abnormalities, you're not able to detect progressive changes, progressive thinning of the macula when the defects, in fact, is happening outside the scan zone. So that's why we actually need to focus on wide field scan. We need to focus on a wider area in order to maximize the probability of detecting change. So we have a model here where we have a study supporting this model, demonstrating that progressive retinal nerve fiber thinning of the palpebral region and progressive GCIPL thinning of the macula, they are mutually predictive. And more important, they are both predictive of future loss of the visual field. So I will come back to this point in the later part of the presentation. When do we need 10-2 to monitor visual field change? We know as glaucoma advances, we have constriction of the visual field where we only have island of vision remaining around the macula. And that's why we focus over the 10 degree in the visual field in the eyes with advanced glaucoma. But I would also like to highlight the fact that we also need to use 10-2 when we don't see abnormalities using the conventional 24-2 visual field. We typically label these eyes to be pre-perimetric glaucoma. Here is a case to illustrate this point. We have an eye, again, the upper panel is the conventional OCT GCIPL RNFL thickness analysis. The lower panel on the left show you a rotor representation indicating a clear inferotemporal retinal nerve fiber defects expanding away from the optic disc margin to the macula. So why, in this case, we don't see visual field damage in this example using 24-2? So is this case a patient with pre-perimetric glaucoma? It's only when we use 10-2 we're able to recognize that there is repeatable visual field defects of the superior field. So why we're not able to detect visual field abnormality using 24-2? When we overlay the visual field stimulus projection with 54 visual field test locations overlaying on top of this 12x9 millimeter scan area, we see very little, only one visual field stimulus projected onto the retinal nerve fiber defects. So it is not surprising that we don't see or hardly see abnormalities in the 24-2 field. It's only when we hear overlaying the 10-2 visual field test locations on these retinal nerve fiber defects indicated here in rotor, we're able to see a much larger overlap between the testing points and the retinal nerve fiber defects. And that's why using 10-2 is particularly relevant. We label this eye to be pre-perimetric glaucoma just because the visual field 24-2 visual field is just not precise enough. It's just not, the testing density is just not high enough for us to detect visual field changes. Doesn't mean this case is pre-perimetric glaucoma. So we have to be careful on that. In fact, Dr. Hu demonstrated in his study that there is a good agreement between structural and functional damage if both 24-2 and then 10-2 visual fields are obtained So using both together actually gets a better agreement, structure function agreement, compared with using 24-2 alone. But testing both 10-2, 24-2 could be very tiring for patients at the same time, same visit. So we have now a newer test strategy called the 24-2C, which provides additional 10 visual field testing points of a central 10 degree. We don't know at this point whether this strategy is useful to detect glaucoma progression, visual field progression, compared with the existing 24-2 strategy. So more studies need to be done to answer this question. Finally, do we need to treat patients with progressive retinal nerve fiber GCIPL thinning without visual field progression? We and others have demonstrated that progressive retinal nerve fiber thinning detected by GPA is predictive of future loss of the visual field. Here is an example demonstrating that, again, the middle panel shows the change map. We have additional thinning of the retinal nerve fiber layer over the infratemporal sector. And this thinning was detected 33 months before we see visual field change detected by, again, GPA based on the EMGT or early manifest glaucoma trial criteria. In a 5-year prospective study, we measure the risk of development of visual field progression in eyes having progressive retinal nerve fiber thinning. And the risk is actually very high. It's actually about 4-fold increase in risk of development of visual field loss defined by the EMGT criteria for eyes with progressive retinal nerve fiber thinning compared with eyes without progressive retinal nerve fiber thinning. Likewise, for eyes with progressive GCIPL thinning for the macula, these eyes also have a more than 3-fold increase in risk of development of visual field loss defined by the EMGT criteria. The rationale of providing IOP lowering treatment is to decrease the risk of visual field progression. And this rationale dates back to a very early study. This is an early manifest glaucoma trial showing that eyes with intraocular pressure more than 21 has a 1.77-fold increase in risk of development of visual field progression defined by the EMG criteria, compared with the eyes with a pressure lower than 21 millimeter mercury. If we are going to provide IOP lowering medications, IOP lowering treatments for patients with a pressure more than 21, how much more we need to be careful about when we see eyes with progressive retinal nerve fiber layer or GCIPL thinning, because these eyes actually has a much higher 3- to 4-fold increase in risk of development of visual field loss. So to summarize, I would like to highlight the fact that it is critical for us to use wide field scan covering both the macula and the parapupillar region to evaluate retinal nerve fiber and GCIPL changes for detection of glaucoma progression. And we need 10-2 to follow to monitor change in eyes with advanced glaucoma and also in eyes with pre-parametric glaucoma defined by the 24-2 test strategy. And then we need to consider additional IOP treatment in eyes with progressive retinal nerve fiber or GCIPL thinning, because these eyes are at risk of development of future visual field loss. Thank you very much for your attention.
Good evening. It's a pleasure to be here, and I thank the APGS for the kind invitation. I'll be speaking to you today about the management of progressive glaucoma, when and what. So essentially, these are my financial disclosures. So before you decide its progression, there are 2-3 things that we need to do. One, we need to confirm that there is progression. We need to rule out other factors that could mimic progression. And we also need to assess compliance before we escalate therapy. So this was a 54-year-old lady with primary open-angle glaucoma, was diabetic, was on a prostaglandin timolol combination. She had reached her target intraocular pressure. And you can see that there's some amount of progression happening there. But when you look at her serial visual fields over time, you realize that the changes are mostly on the mean deviation plot. And she was basically getting significant lens changes, which are accounting for this. And this is not really true progression once you rule out confounders. So for any patient, what additional information would be required? One would be whether the previous target intraocular pressure has been reached. What is the diagnosis would matter. How long it is since treatment has been started. Are you seeing progression early or late in disease? How much functional damage there? What is the potential life expectancy that this patient has? What are the number of glaucoma medications this patient is on? And other factors such as cataract status or precipitating factors. And we sort of use some of these factors to decide whether to consider medical, laser therapy, or surgery. So in general, if progression is occurring late in treatment, you might consider escalating medical therapy. With milder disease, again, you might prefer medical therapy. When the life expectancy is short, not being very aggressive makes sense. And if they're already on on 1 or 2 glaucoma drugs, you could consider escalating therapy. And the converse is obviously true when they have progression early in disease, greater field damage, longer life expectancy, or they're already on a fairly large number of glaucoma medications. The second question is whether the previous target intraocular pressure has been reached. And if the answer to that is yes, once you have ruled out confounders such as lens changes and non-compliance, and you've ruled out transient fluctuations in intraocular pressure, which are more common with secondary glaucoma, for example, the intermittent steroid use or the use of steroids for an acute COVID episode or a flare-up of uveitis, all of which could have caused an IOP spike. Once you have ruled these out, then or the patient's target intraocular pressure has not been reached, obviously you would consider escalating therapy in terms of drugs, SLT, or surgery. But keep in mind that every additional glaucoma medication that we add has reduced intraocular pressure lowering efficacy. And this paper by Handry, Jampel, and others looked at the effectiveness of intraocular pressure lowering medication as determined by washout. They included about 603 patients who were on multiple medications, and they looked at the intraocular pressure in these patients once medications had been stopped. And I'll just refer you to this table over here. So this basically tells you that if you stopped off one drug, and the patient, when the patient was on a single drug, you got an average of a 33% intraocular pressure drop. When you stopped off the second drug, you got a 9% intraocular pressure drop. When you stopped the third AGN, you got approximately 13% intraocular pressure drop. So as you keep escalating the number of medications, the additional intraocular pressure reduction that you get is actually not very large. So we'll move to this example now, which is a 58-year-old male with primary open-angle glaucoma, was on a beta blocker brimonidine combination. He had reached the target intraocular pressure that we had set for him. And what are the options that you would consider for treatment here? He basically has fairly mild disease with a mean deviation of about -5. And to my mind, medication or SLT would be reasonable options in this case, because he's progressed fairly late in treatment after having fairly stable disease course. The disease is mild and he's just on a single combination. I would definitely consider adding a prostaglandin as an option in this patient, or considering SLT as a alternative. But look at the other eye of the same patient. So his risk factors are similar. He's on the same beta blocker brimonidine combination. The target intraocular pressure has been reached. We've ruled out other causes here. And here, I might consider a very short trial of medical therapy, but I'd have a very low threshold for surgery for 2 reasons. One, he's got fairly significant damage, and the damage is showing multiple points adjacent to fixation which are affected. So here, because he has moderate to severe damage, he's got a relatively long life expectancy, and he has damage adjacent to fixation, surgery would be, my threshold for surgery would be very low. So this is a 38-year-old male with juvenile open-angle glaucoma on treatment since the last 22 years, and as you can make out, is fairly stable. He's on a prostaglandin timolol combination, and recently his intraocular pressure started crawling up. It's about 2 millimeters more than the target that we set for him originally. And when we look at his visual field, you do notice some amount of progression happening there. So you would consider, looking at this field in isolation, I would consider escalating treatment here. I would not really pay too much attention to SLT since he has GOG and the effect in GOG can be uncertain. So this is somebody who is, again, late in treatment, mild disease, but very long life expectancy ahead of them, which is on the other side, and he's on 2 drugs. So again, it makes sense to go closer to medical or laser therapy in this patient. But when you also take into account that he's one-eyed, and again, you're seeing some damage, early damage adjacent to fixation, you could consider surgery as an early option because this is somebody who's got a very long life expectancy to go. And on top of it, this is the only seeing eye that the patient has. This next example is an 85-year-old man with primary angle closure glaucoma. Intraocular pressures are slightly borderline in terms of target IOP. He's on prostaglandins and brimonidine. And the visual field definitely shows significant changes over time, and you're seeing a fair bit of change there. And I'd like you to pay attention here is that he is showing a sort of episodic progression. This is the first, when you look at his rate of progression right from the beginning or here, he's been progressing at about this 3% per year over time. So this is somebody with moderate to severe disease, but he's 85, fairly short life expectancy. And you would consider, because of his low risk of visual impairment, even though there is damage which is somewhat central, you would consider SLT or switching him into a brimonidine, switching the brimonidine to a brimonidine plus carbonic anhydrase inhibitor combination. This next example is a 38-year-old man who's on treatment for 3.5 years. Intraocular pressure is on target, on prostaglandins and brimonidine, but he is showing progression. And this becomes a little problematic. I would consider surgery here for the single reason that he's 38 years old and he's progressing rather rapidly. And it's very early in disease. So he may be one of those rapid progressors whom you need to detect and control adequately so that you don't, they don't have significant visual field loss in a very short duration. And following surgery, you can see that he stabilized and the visual field damage sort of halted at that point in time. This next lady is 61 years old. She's on treatment for the last 10 years. The intraocular pressure is slightly borderline on prostaglandin and brimonidine and timolol. She's progressing at about 4.7% per year. Considering this already on 3 glaucoma medications, one of the options that we could consider here was surgery because adding additional medications is not that easy to use. So this is somebody who has basically mild to moderate disease, but is progressing fairly early in treatment, has a long life expectancy, and is on 3 or more drugs, so surgery seems to make sense. But when you take into account that she's a 15 diopter hypero, and she's actually in borderline nanophthalmos, so she's a high-risk candidate for any glaucoma surgery. So we decided to add brinzolamide in combination with brimonidine instead. So when we're making a decisions in progressing glaucoma, in addition to the normal things about the amount of field damage and other things, it's important to keep in mind what the diagnosis is, whether the previous target intraocular pressure has been reached, whether there is threat to fixation, what the fellow eye vision is, and keep in mind always the risks of surgery so that you can individualize a decision regarding escalating medical management, SLT, or surgery. Thank you.
Okay, and now we've reached the part of the webinar where there's an opportunity to ask questions and receive answers from all of our speakers. You can submit your questions via the green button below the webinar video if you just click on that link. I'd like to thank my fellow speakers, Ronnie, Mimiwati and Christopher for their excellent presentations, and also in particular thank Allergan for their sponsorship of this webinar. I might start off with a question to Mimiwati if I can. Mimiwati, you've mentioned quite a number of risk factors for glaucoma progression. I was wondering if there is an algorithm or formula that can be used that puts all those together to calculate an individual's risk.
You mean an algorithm to put everything together?
Yes, or even some of them.
Well, you can use the ocular hypertension treatment calculator for one. But personally, no. You know, I don't know of any that puts everything together. What about you? Are you using any particular one?
The only one that I use is the ocular hypertension treatment study
Right.
calculator. Yes.
Right. Can I just ask if anybody practices phasing regularly amongst your patients?
Well, we do phasing, but only daytime office diurnals, basically. And we're just trying to see whether we can use the eye care home tonometry also in addition to that.
Right. So do you rent, do you loan the eye care to the patients to go back?
So we've just started a pilot where we're looking to rent it out to the patients for a day or two and see how that works out. But it's not that easy to use. I've tried to do my own, and it's not that easy to use. It just takes a little getting used to.
And the daytime IOPs that you're mentioning about is just in office?
Just in office, 8 to 4, 8 to 5.
We do water drinking provocative testing as a surrogate for that.
Mm.
We did look at the water drinking compared to the daytime phasing, and we did not find very good correspondence. So that's one of the reasons why we stopped using it. But of course, you don't know what's happening in the non-office hours, so it could well still be a pointer for progression.
I think there was one study which says that you take a supine daytime readings, and that correlates more with your long-term progression readings. I think there was a question just now that popped up, which I saw.
Makata, did you have a question for?
Yes.
Ronnie?
Yes. The audience asked. So based on your talk, OCT macula is a must for all stages of glaucoma. How sensitive and specific is OCT macula in advanced cases? So this is a question. So somebody can answer this.
Right. So I think it's from a talk. I believe it is very important to include the macula for all stages of glaucoma. It's been shown in some studies that even in advanced stages of glaucoma, the macula is more useful in terms of detecting change, in terms of detecting GCIPL loss, compared with the papillary retinal nerve fiber layer. So macula could be particularly helpful in those cases. The rationale, as I mentioned in the talk, for including the macula is that you would like to have a wide field visualization of the distribution and the extent of damage of the retinal nerve fiber and GCIPL. That's why we don't want to limit ourselves to just a circle scan of the RNFL. We just don't want to limit ourselves to looking at just the macula. We would like to include, that's why we call it wide field. The current OCT we have is relatively limited in providing wide field scan. Some OCT models, they do provide wide field scan, but some don't. But for those models, they would often have a particular scan protocol for the macula, and then another one for the RNFL for over the papillary area. So I would suggest to include both areas if a wide field scan protocol is not available. Macular imaging, power papillary region imaging, wide field is very important.
Thank you. So Colin, could you select the next question?
Yeah, there's also another question for Chris on what would you consider to be significant RNFL or GCL loss progression, and during what period of time do you consider augmenting the treatment?
It is a great question. I'm not sure if I have a good answer to that. What is significant? Does it mean statistically significant, or does it mean clinically significant? Obviously, we also know we have age-related loss of RNFL and GCIPL. So would that mean that we also need to treat glaucoma patients or for any eyes that show statistically significant RNFL thinning? it's important for us to bear in mind that the studies that we've done and from others, the idea here is that for eyes having progressive RNFL or GCIPL thinning, this eye have a very high risk of future loss of the visual field. For those studies, what we know about is they really didn't take consideration or differentiate age-related from disease-related loss. So it's really hard for us to judge whether it is clinically significant. But I would take a perspective that given the fact that in glaucoma patients, the RNFL and GCIPL, they are already being abnormal. Even for age-related loss, actually any additional loss of the RNFL or GCIPL, they would probably induce further loss of the visual fields. So given this perspective, I would more incline actually to be more cautious and also to be, more likely to provide treatment whenever I see a loss of RNFL or GCIPL in our OCT analysis.
Thank you. So next question, maybe, so this is for Colin. So QOL is sort of personalized question, quantification of the impact of glaucoma to their daily living. Do we really need a standardized QOL questionnaire? So how do you think?
So my comments in relation to that are really that the current instruments that we are using are not measuring the same things. So depending on which instrument you use, you're looking at a different metric and you're going to get a different outcome. Some are very vision specific, some are not vision specific at all. They look at other aspects of quality of life. So the comments surrounding that are that we should be looking for an instrument that captures all aspects of quality of life that are impacted by glaucoma. And once that's standardized, then you can compare from one population to another, from one treatment to another, from other interventions. If you're using different metrics, it's very hard to compare and make conclusions from it.
Thank you.
And I think there was another question for Chris about, actually I have one for you, Chris, which was, with visual field testing, we know that the frequency that we do testing determines how quickly we can pick up progression, and that's partly related to the fact that it's a subjective test. Given that OCT is objective, is frequency of testing as important?
Well, we do need both structural tests and functional tests to give us the full perspective of our patients. We need to know both the structural and functional integrity of the optic nerve. The issue about how frequent we would need to administer this test would, you put it rightly, that the more frequent we administer, the more likely we'll be able to detect change. Probably we need more frequent visual field testing just because of subjective natures, just because of the intrinsic higher test variability associated with visual field testing. And that's why when we want to know whether there's functional loss, we need to test more frequently.
Thank you.
So the next question is, so when to add 10-2 in regular field testing? So does it require to be done in every visit and every case? So
great question. It's hard. We all know it's very, very challenging to ask a patient to do both 20-2 and 10-2. I still believe the current standard, still 24-2, to get a really good idea about both the central and paracentral area, because we know glaucoma patients, they tend to have arcuate defects, and these arcuate defects tends to give rise to nasal stap, and that's why 24-2 would be particularly useful. But we also know more and more now that the central area can be affected in glaucoma, and very often, as I show in the talk, there are patients where we see we label them to be pre-parametric glaucoma just because the visual field damage is not there, in the 24-2 doesn't mean that there's no visual field defect. The visual field test we're using is actually not very precise, and that's why 10-2 is particularly useful. But we don't have a good solution covering both 10-2, 24-2 at the same time. That's why the newer testing strategy, the 24-2C, including the additional 10 test locations of the central 10 degree, would be particularly useful in my opinion. But we need to see whether this is something that would become our new standard for visual field monitoring. We need more data to support the use of it.
Okay, so thank you everyone. So the time is coming. So today we learned a lot about glaucoma, so how to manage glaucoma progression. So there are many aspects to manage glaucoma progression. So we put together and evaluate in the proper way. But one of our challenge is how to assess the compliance of the patient for medication. So that's very important, but it's very hard to evaluate, I think. So anyway, thank you for all wonderful talk for all speakers. So I really appreciate your attendance for this webinar. And also we need to thank Aragon to support this webinar. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you everyone.